I'm Dr. Matt Davids. I'm a CLL specialist at Dana-Farber Cancer Institute in Boston.
Hi, I'm Debbie Stevens. I'm a CLL specialist at the University of Utah Huntsman Cancer Institute.
So thanks for joining me, Debbie. It's great to chat about some of the exciting ASH abstracts, and one in particular was a trials in progress abstract that I was really excited about, which is your SWOG intergroup study of early intervention with venetoclax obinutuzumab. And this is clearly a very important area in CLL research. We tell our patients watch and wait, and this is very challenging for our patients to understand. And when we look to the data to support that approach, there's very little data with novel agent-based therapies. So maybe you could tell us a little bit more about how this study came about.
Yeah, great questions. And I think the whole basis for why we do watch and wait is because there have been some old studies with our old chemotherapy-driven regimens that have not shown a benefit in terms of how long people can survive with CLL based on doing early versus late treatment. However, now we have this whole subset of our novel therapies that are less toxic and very effective at treating CLL. And so we actually looked at a regimen called obinutuzumab and venetoclax. So obinutuzumab, of course, is an intravenous therapy, a monoclonal antibody paired with venetoclax, which is a oral pill. It's an inhibitor of something called BCL2. And the reason why we chose this regimen is because it's very effective in treating patients with CLL that have not been previously treated. And it's a time-limited course. And so when you're talking about doing earlier treatment, you really want to limit the length of time that you need to have people receiving therapy. And so this regimen is designed to be only a year of therapy. And so, it's effective, it's minimally toxic for people, and it's time limited. And so it seems like a really great regimen to ask the question again, should we be treating people earlier with CLL instead of waiting until a time when they develop symptoms or low blood counts?
I totally agree, especially as compared with the strategy of a continuous BTK inhibitor. Here it's a time-limited therapy, and if you can show a major difference, that's going to be a huge advance for patients. So how are you going to measure this? What's the primary endpoint, as we would say, of the trial?
Now, the primary endpoint of the study is overall survival. So that means how long people can live. And we want to help people to live as long as they can, as healthy as they can.
That's great. I mean, I think that's really the right endpoint to be looking at here, because that's what we really want to show is that, if we can make patients live longer by intervening earlier, then it's really meaningful. And so I definitely applaud you for choosing that as an endpoint, even though fortunately it's going to take a long time to read out because patients will live for a long time. So another question I had was around the eligibility for the trial. If you're a patient out there and thinking about you might be interested in this trial, what are these specific requirements?
Well, we thought that it would benefit the patients that we characterize as high-risk disease the most, because these are the people who are at highest risk for a short time until first treatment, or a short overall survival, or short time of living with CLL. And so we have defined high risk in our study. We use something called a CLL International Prognostic Index. And this is a combination of both clinical risk factors and some of the lab-based risk factors that we use. And so we use items like stage of disease, age of a patient, and we use important molecular markers called TP53 or deletion 17p. We also use some markers called the mutational status of IGHV and a beta-2 microglobulin. And so when you put all of these factors together, you can get a score, and a score of 4 or more would qualify you for the study. We also allow patients who have something called a complex karyotype, and that's whenever we do genetic sequencing of a patient's CLL cells, we find that they have multiple mutations. So 3 or more mutations that might mean that they have a chance for earlier treatment or shorter survival. So basically, we look at high risk, and you're probably going to need your doctor's help to figure out if you're high risk or not, but happy to help in any way that I can. Another important thing is we're really looking for people with newly diagnosed CLL. And so that means that you need to have been diagnosed within the last year to qualify for the study.
That's very helpful. So, sometimes when people hear the term randomized, they think that there's a placebo arm of the study. So is that the case here, or how does the randomization work?
Yeah, there's no, placebo or sugar pill or fake pill that people are receiving. And right up front, once the computer does the randomization, patients know what they're going to get. So they know if they're going to immediately start treatment with venetoclax and obinutuzumab, or they would do what we do standard of care right now is wait until a time when they develop symptoms or, low blood counts and they require treatment per standard guidelines for CLL. One thing that's really beneficial is though, whether you get early treatment or late treatment, this clinical trial has offered to pay for all of the therapeutic agents. So any of the drugs received on therapy would be completely paid for and not billed to a patient's insurance.
Fantastic. I think this is a great study. I know I'm very enthusiastic about it and eager to see results as they emerge. So any final thoughts?
Yeah, I would just say if people are hearing about this, one way to find more information is going to clinicaltrials.gov. And the study is the S1925 study. And so if you just type in CLL as the disease and search for S1925, there will be a whole list of locations where this is available. And it's available really across the country. And so patients might be able to find a center that's close to them, and contact information is listed on that website as well.
Wonderful. Thanks so much, Debbie. Once again, I'm Matt Davids. Very happy I was joined by Debbie Stevens, and thank you very much for watching.